I think you can see there is a bright, if complex future, and we're really going to have a new concepts of disease. Our classifications are pretty primitive, and we're going to understand much better. We have a ways to go, but I think that's very exciting. This is an important part of the future of nephrology, and it's an exciting part, just like new dialysis, regeneration of the kidney, tolerance, xenotransplantation. We have some wonderful pieces here. Well, we're going to try to put everything together now. Tim Garson has been charged with this task. Tim is the Executive Vice President and the Provost of the University of Virginia and the Robert C. Taylor Professor of Health Science and Public Policy. He is a pediatric cardiologist, but he's been very much involved in public health or health policy, the White House panel on health policy, the American College of Cardiology's Task Force on the Uninsured, the Working Group on Systems to Improve Quality Care, and the list goes on. But I'm going to ask him to bring up the panel, Dr. Straub and Stan and Anders. If you could, are you going to, how do you want to do it? And then sit over there, because we'd like to have questions and discussions. So, Tim, are you going to lead off then? All right, very good.
We're done at 6 o'clock, that's right? Well, thank you, Barry. I figured the best way to sort of bridge between genetic susceptibility to kidney failure and health reform is to talk about the molecular genetics of the Senate. I think maybe I'll ignore that for the time being. Do I just maybe do that? Or, hey, there we go. Let's see. Oh, terrific. Thank you very much. How a self-respecting pediatric cardiologist stands before you to talk about health reform, I thought I might at least share one anecdote with you. And that goes back literally to my first night on call, a fair number of time ago in Houston, taking care of a 5-year-old after she had her surgery to repair being a blue baby. And she arrested 3 times, and each time, and probably the vast majority of you in the room have been through this, you go back and you talk to the family and you do the art and the science of medicine, and you alternate the art and the science. You do the science, you do the resuscitation, you do the art, and you go back and you talk to the family. And this happened 3 times through the night. And at the end of that night, as frequently happens, we bonded, the family, the child, and I. And she made it through the night. And over the next probably 5 years, I saw her weekly and then monthly, went to her grammar school graduation. Somewhere in around the age of 16, she developed a heart rhythm problem, which I was doing investigation on at the time. We had her on a very good medicine, pretty expensive medicine. We had her on a pretty good medicine. Went to her high school graduation, and the dreaded call at the age of 19 and a half came from her mother in hysterics that she had found her dead in bed on a Sunday morning. And as we put the pieces back together, it became real clear that my favorite patient had never refilled her prescription after her Medicaid ran out at the age of 19. So the United States of America had created a program that took care of somebody, stem to stern, and dropped her at the age of 19, and she died. And if you don't think that got my attention, ladies and gentlemen, in terms of saying, all right, this system is terrible. And I then got into the idea of trying to help in what little ways I could over the next 20 years to try to see if we couldn't change the system. I take absolutely no credit for what has happened in the last year, but I am proud of America for doing it. I take very little credit except being the picador in the bull ring What's happened has happened. I am thrilled that the ball has moved. Many of us have issues with some of the specifics, but I got a number of emails the day after the legislation passed from France and Canada and a bunch of places, and you know, congratulations, and I wrote back and I said, I didn't do anything. But we had to start somewhere. So what I will share with you is, I'm happy to tell you, the Affordable Care Act in 5 slides. So we'll see if I can get it down to 5 slides for all of us. The real essential parts of it, and then what I really do want to do is spend the next 6 or 7 hours discussing that's what you told me, right? No, maybe not. The next 6 or 7 minutes discussing how the Affordable Care Act really might have effects on patients, the Rogosin Institute, and the hospitals surrounding us. Then we'll go from me to Stan Dorn, who is health economist par excellence, who tells me he plays one on television, but he does a whole lot more than plays one on television. Anders Christensen is going to talk about some very interesting things they're doing in Sweden, and then we'll all get together and end precisely when Dr. Smith tells us to. So the thing that people forget when they get down into the weeds of the Affordable Care Act is that it provides health insurance coverage. And the big thing that it does, and the thing that it does very successfully, is it says we understand in the United States of America that we need to provide health insurance coverage. You may think about why it is that America is in the 40s in terms of life expectancy and infant mortality, 40th from the top in any country in the world. We are terrible. A fair amount of that actually has to do with a lack of health insurance. A fair amount of that. When people look at the reasons for life expectancy, interestingly, 40% of life expectancy in the US is due to lifestyle. 30% is due probably to genetics, 20% public health, and 10% medical care. 10% the sort of things that we do that doctors and patients do. A lot of lifestyle, and fortunately a lot of genetics of what we've been talking about. But part of lifestyle is, do you have insurance coverage or do you not? So the Affordable Care Act has gone a fair amount of way of getting us there. Currently 83% are covered with health insurance, and the Affordable Care Act, now it says it will cover, the reason 32 million is in quotes is that's an optimistic estimate, I believe. But certainly, as we'll see in a minute, 16 million to be newly covered by Medicaid is probably really going to happen. But the issue that will be before us is that 22 million legals, in addition to 6 million non-legals, 22 million legal people will be uninsured by 2020. Now you've heard Barry and others, you've heard both Barrys say this morning, that coverage is not the same as access. Coverage means you've got a health insurance plan. Access means you can see somebody. And we got to see that experiment. In 2006, Massachusetts came up with their own health plan and reduced the uninsured down to 2.5%. They had gone from 10% uninsured to 2.5% uninsured. The average now in the country is about 16% uninsured. Massachusetts took the bull by the horns, reduced the uninsured, and the wait to see a primary care doc increased from 33 to 52 days. So you will hear a lot over the next, even recently and moving forward, about problems with access to physicians, whether they are primary care docs or nephrologists. Now, 50% of the insurance coverage is going to be provided by Medicaid expansion and the other half by private insurance. There are insurance exchanges. The premium, pick a number, probably around $6,000 for an individual. And in order to allow people, the Accountable Care Act has said in order to allow people to pay for their own health insurance, they will subsidize up to an income of about $43,000 per year, or 9% of income. Now, Medicaid covers the poor up to 133% of the federal poverty level, which for an individual gets you to about $14,000. Private insurance above that. I would point out if you said to me, what's the single best thing the Affordable Care Act did? Medicaid did not cover people like my patient. Medicaid stopped at 19 and started at 65 unless you were blind, disabled, had chronic renal disease for a couple of years, interestingly enough, or never worked. There's some interesting parts of it. But by and large, if you were a single adult and you made no money, as my patient was a single adult and made no money, you were not covered. Medicaid now covers everybody up to at least some small income. Now, the individual mandate is in quotes because the mandate says if you don't have health insurance, you must pay $695. Well, that's not a whole lot compared to paying an individual premium of $6,000. Now, nobody's going to pay that whole premium. Remember, there are subsidies. But the penalty of $695 is not thought to be a very high penalty, nor is the employer responsibility, otherwise known as an employer mandate. At $2,000 per worker, you'd say that's a lot of money, unless you're talking about what the insurance company would have to pay if they had to cover somebody. So the employer responsibility, the individual mandate, not perfect, but certainly at least something one can point to. Insurance reform, you've heard a lot about elimination of pre-existing condition exclusions, the things that the insurance companies have been told they must do, having community rating, and they must spend at least 80% of their premium to pay for care. That's a term that offends much of us, of the medical loss ratio, which is, they call it the medical loss ratio, meaning what do you lose on paying for medical care, and that's the 80% number. A word about pre-existing condition exclusions. This is going to sound arcane, but it may not be. The pre-existing condition exclusion, in the absence of a mandate, is the only thing forcing somebody to have health insurance. Let me say that again. Because, the pre-existing condition exclusion sounds like, well, it's draconian, it's horrible, it makes people, not get health insurance. But think about it. The pre-existing condition exclusion, if you have no pre-existing condition and you say, uh-oh, I'd better sign up for health insurance before I get a pre-existing condition exclusion. It's the only thing that stimulates people to get health insurance. Otherwise, if there were no pre-existing condition exclusion, people would simply say, I will wait until I'm being rolled in for surgery and ask for health insurance, and I have to get it. So the pre-existing condition exclusion is draconian, it's awful, it's terrible, it's every one of those adjectives, except it is essential to having healthy people sign up for health insurance. It's essential for having healthy people sign up for health insurance unless there's a mandate. And so there it is, just to give you a little bit of a thought about the pre-existing. I could not be more delighted that the pre-existing condition exclusion is gone. I just want you to understand why, in fact, what people are talking about is that insurance rates may go way up, which I'll talk to you about in a minute. Now, you've heard a lot this morning from Dr. Straub, and I don't need to spend a whole lot of time on what's could happen to physicians and hospitals in the Accountable Care Act. I think important to Rogosin, which I will deal with in a minute, are some of the demonstrations of new ways to pay physicians. I learned something this morning that knocked my socks off that those of you that do this for a living, like Barry and Stan, probably knew about. 60% of physicians in the United States are currently not paid fee-for-service. which blew me away. The usual way that we all think that docs get paid is you do something and you get paid for it. And you do more of it and you get paid more for it. Well, lo and behold, 60% of docs in the United States as of this morning are not paid fee-for-service. They're paid pretty much on salaries, and many, many more increasingly by hospitals. So it's very interesting to me that it's a problem. Fee-for-service is, and I understand, thank you, Rogosin. Rogosin is paid salary. University of Virginia is paid salary. It eliminates the temptation to do more to get paid more. But there are demonstrations of new ways to pay docs, certainly prevention, workforce, a big interest of mine. There are grants to states, and you heard a lot this morning about hospital payment for quality. And yes, over time, the Medicare payment update may be reduced to hospitals. Now, I also saw this morning that in terms of, and this is the last slide on this, that the cost and deficit numbers now have error bars of $1.5 trillion on either side of zero. $1.5 trillion on either side of zero, meaning that the eventual, at the end of the 10 years, it could cost $1.5 trillion or it could save $1.5 trillion. Now, that kind of precision will really get us a lot of places, folks. But I've seen, and both of those numbers were in an article in the Washington Post this morning. There you go. Where does the money come from that they're talking about? You've seen all this. The Cadillac plans are the very expensive health plans, largely covered currently by unions, tax on high income investment, people with high income and investments, and the things that you can see there. What I would spend just a minute talking about are below where it says not counted. And in all fairness, the Congressional Budget Office has very strict rules of what it can count and what it cannot count. But what it has not counted are, for example, electronic medical records. In terms, you've heard a lot, some very, very exciting things going on in electronic records. Well, if you got rid of billing, Jonathan Lorch said last night at dinner, not having had a lot to drink, that you know, if you just don't make me bill, imagine what I can save. So imagine that if there are, in many practices right now, 2 billing clerks per doc, and all of a sudden, no more billing clerks. Just imagine the administrative simplification. Imagine when you go to the clinic, how many times you get asked for your address over and over and over again. And so even the administrative simplification, not the important quality indicators that you've heard that are so important that are going to start coming out over the next several years, not counted in the CBO calculations. Reduced practice variation. There is a 400% variation in the rate of coronary bypass surgery between Salem, Oregon, and Miami, not much of which is accounted for by being sicker. So there are communities where it is acceptable to do an immensely high rate. McAllen, Texas is the one that you've all read about from the New Yorker of last June. Immensely high rates of variation in the same patient with the same outcome, but 4 times the amount of procedures being done. There is an article where we did a calculation. There is a rate of increase of healthcare costs. Usually it's about double inflation. So I mean, or you sort of add the medical rate of inflation goes up 6.5%, regular inflation goes up 3%. So I mean, the total medical plus regular. So if you take the average of about 3.5% increase per year as the average in what goes on in medical inflation, and you then apply the numbers for San Francisco, and you go from 3.5% to 2.4% in San Francisco. Now remember, we've all been to San Francisco. That is not necessarily seen as the most healthy place in the world, even though Dr. Straub does originate from San Francisco, so he adds to the health. But it's not seen as you know, pristine Rochester, Minnesota. You get down that percentage point from a 3.5% increase per year to 2.4 increase per year, you save $100 billion a year for Medicare. So those kinds of things are not in the model. Improved delivery models, which I will tell you about a very quickly, a model that we're going to be working on here that improves care and saves money. So my personal view is there is more in there to be saved than the Congressional Budget Office talked about. On the other hand, on the other side, there may be more expense than has been recognized as well. And so plus or minus $1.5 trillion, you know, trillion here or so. So that's it. That's the Accountable Care Act in 5 slides. Largely covers a whole lot more people, even though leaving 22 million behind. A lot of insurance reforms. And when you talk about cost and quality, what you see is the word demonstrations more than actual statute. Now, what's going to happen to patients? Okay, reduced but not eliminated uninsured, may not improve access to care. Remember, covered. Now we've still got the problem of getting to see a practitioner. My sense is that over time, premiums really will increase. I know you read in the paper there are all kinds of different segments of the population that different things will happen to. But it is I hope I'm wrong, but I guess I'm allowed to guess, that what I really do think is going to happen is that without a stronger set of mandates for people to have health insurance, they will not buy it the way that people thought they should, thereby leaving the healthy will not be insured, the unhealthy will be more insured, and premiums could increase. Quality and appropriate care will improve, hopefully will improve more than slowly, and administrative hassle by virtue of, I think, once everyone has an electronic health record, and this is not just because I want Jonathan to buy me a drink, we're done. The quality of care is a step function, and along with quality of care comes reduction in expense. If everybody in the United States has an electronic health record, and when they do, you will see a major change in medical care and in health care. So you've seen, and I'm going to go very quickly here in terms of some of the Rogosin effects because you've heard some of these already this morning. I think insurance rates could spiral upward. There are opportunities for physician-hospital alliances that you may hear some more of from Stan. There are certainly opportunities for workforce innovation. We know that if we, for example, said that doctors help us, doctors don't have to do everything, and nurse practitioners and nurses can become elevated and help more. And in fact, as you heard Barry Smith say early on, what we'd really like to do is get the public to be part of the healthcare workforce. Think of the public as part of the workforce. Think of the public as being our partners. We then leverage the public, nurses, leaving docs to do the sort of things that they must do. Lo and behold, the shortages may be a little bit less than one would think. We hope, I hope, as a specialist, that we stop the snickering between specialists and generalists. This is all part of a team. You will hear snickering all over the place. It's just a waste of time. What we ought to do is work together, docs, nurses, specialists, generalists. Is that a pie in the sky? I think not, as you will start to hear when you've heard these accountable care organizations, when you're about to hear some of these things from Stan, when you're going to hear some of these things from Andrus. There is a move toward us all working together, and it will be, I think, high time. A very quick thought about a program that we've called Grandaids, which is literally hiring grandparents, lay grandparents, to do work that they can do with about 6 to 12 months of training. You do not need a nurse to go home with the patient the day of discharge. So you've had your kidney transplant, you go home with heart failure. Simply having a person of knowledge go home with you that says, show me your medicines, show me how you're going to remember to take them, show me your scale, show me what you're supposed to weigh. Those kinds of things are very, very simple to do. In fact, there's a program in San Francisco coming out of the University of California, San Francisco, where they have peers doing chronic disease, where somebody who had a renal transplant would go home with somebody who had a renal transplant. There are a number of other things that grandaids can do, actually, including primary care, where we could, in fact, we've done an analysis in the University of Virginia emergency room. If we teach grandaids to do primary care, we can reduce emergency room visits by 26%. Now, a big increase in Medicaid makes Barry Straub happy, because that's a lot of good news and a lot of good work that CMS is doing, but gets to do a lot. But if there's a large population of the uninsured currently seen by a hospital or physician, payments will increase. Currently, Rogosin does not have a huge proportion of Medicaid patients. But what could happen over the next several years, due to an arcane way in which they've chosen to pay for this, is in fact Medicaid payment of newly covered people. The federal government covers 100% for several years, and then it drops it to 90%. And 10% of a big number in terms of now the states having to cover 10% of newly insured people could cause the states to balk. We've already seen docs refusing to see Medicaid patients, and a number that came out 2 weeks ago that 68% of physicians predict that access to Medicaid patients will decrease. I hope that's not true. We'll still have a bunch of uninsured, and so we will still need systems to take care of the uninsured. We will still need safety net hospitals. We will still need community health centers. Now, let me finish with sort of the unique, what's wonderful about Rogosin. The advantage here, and we've heard it this morning, we've heard it with a lot of people yesterday talking among ourselves, is this is hopefully not so unique that others can't learn from it. But this is a pretty unique, in order for Barry Smith to put together a symposium like this, the breadth of the people that work here, the breadth of the people that think here is phenomenal. Think about a few things that Rogosin can do: healthcare delivery models, developing appropriate care based on individual patients. You heard both of the gentlemen this morning talk about the idea of subpopulations accessible from an electronic health record. Let me give you an example of what that means and how that would work here. Charlene comes in renal failure. Patient Charlene comes in with renal failure. Charlene has 50 different measurements made on her. Blood tests, blood pressure, weight, da-da-da-da. Jonathan goes back to the Rogosin database and finds 350 patients that on a given day were exactly like Charlene. That's the subpopulation. Exactly like Charlene. Pulls them up and says, what happened to these 350 patients? What did people do to them? How were they treated? And all of a sudden, 90% of them did real well and 10% of them didn't. Those kinds of very, very specific, patient-specific guidelines, patient-specific advice are possible here with a pretty unique database that you've got. Certainly models for public health programs. There are those of us that have proposed a fat tax. We'll get there. And as you will hear in a minute, Stan and I did that one together, and you'll hear a whole lot more from Stan about this last thing about patient-centered specialty medical home. what would we do here to get from data to policy? Well, it's a pretty well worked out, maximize quality, promote it, and then create policy change. So what we're after here is integrating, as you've seen so well here today, patient care research and policy, hopefully to create better health for those who have kidney disease, and ultimately as a model for those who have other chronic diseases, even diseases like heart disease. Thank you all. Stan Doran is next. You're in for a treat.
You can hear me? Okay, excellent. All right. Well, it's a pleasure to be here today. I've been trying to think about why Tim keeps accusing me of being a health economist. I'm not an economist. I work for economists. I've tried to learn from them, but I understand why. How many of you are physicians? Raise your hand. All right. I'm a lawyer. That's why I keep Tim. If Tim could have told you I'm an economist, I'm a garbage collector, what have you. But the truth is I'm a recovering lawyer, haven't practiced for many, many years. So please, my dad was a doctor, so have pity on me, even though I'm not an economist. Think of me as one, if that makes it easier for you to hear what I talk about in the next few minutes, which will be two things. Let's see, there we go. I'm going to talk with you about some of the key provisions of the Patient Protection and Affordable Care Act, sometimes called PPACA. How many of you heard the acronym PPACA before? Some of you heard it, all right, but many of you haven't, so my talk has now accomplished its objective, which is to teach you a new acronym that you can use to impress your friends and neighbors. And then what are some opportunities for nephrology given the new federal legislation? Now, one of the objectives of the federal legislation is to slow the growth in healthcare costs, which has been ruinous, both to public and private payers. And traditionally, you have an argument that goes something like this. From the right, well, the problem with American healthcare is that consumers don't have enough skin in the game. And we need to have demand-side pressures that slow healthcare cost growth. So we need to make consumers pay more, so they'll think more before they decide to get a particular service. Demand-side cost control. And then from the left, you get more of a supply-side cost control. Well, what we need to do is control prices. We need to reduce the number of hospital beds, reduce the amount of infrastructure, have global budgets. That's how we bring cost control into effect. And the common assumption of both of these is that healthcare is this fixed thing. It's this widget. And really the only issue is, do we have more of it? Do we have less of it? Do we pay more per widget, or do we pay less per widget? And that's been sort of a sterile, unproductive argument going on for decades. But there's another way one can think about it, a third way, if you will, which is, what if we change the widget? What if we change the type of healthcare? The intuition is that 20–30% of what we do today doesn't really benefit the patient. And that the incentives are wrong. The incentives are for each little part of the healthcare system to make as much money as possible by selling its particular product or its particular service, whether or not that actually benefits patient health. And maybe there's a way we can change things. And one has hope because there are examples of little islands of success. Mayo, Geisinger, there are others, places where healthcare is cheaper than in the country as a whole, but also higher quality. Maybe this gives us hope. There's a way to change the widget so that cost growth slows while patient well-being increases. But even though we know there are these examples of success, how do we move from these archipelagos of high-quality, efficient care to a continent of high-quality, efficient care? How do we scale up? Not necessarily so clear. And so because we don't really know the exact route, PPACA says, let 1,000 flowers bloom. Let's try this. Let's try that. Let's try all these different kinds of things. And if some of them work, well, we're going to transplant it and hopefully reach a continent, more or less. So what are some examples? It sounds like you all have been hearing a lot about PPACA as time goes by. I'll mention a few examples of the flowers that PPACA fertilizes. I'm not going to push that analogy any further than that. So the Center for Medicare and Medicaid Services has a new institution being created called the Center for Medicare and Medicaid Innovation. And it has $10 billion that are appropriated in PPACA, which is a big deal, over the next 10 years, to invest in testing innovative models of reimbursement and care delivery. It's an incredibly broad mandate. The statute has 15, 20 different models that this new Center for Medicare and Medicaid Innovation can experiment with. And then at the end they say, anything else that looks good, you can go ahead and experiment with. And what's remarkable about this particular provision is that CMS doesn't have to wait for Congress to say yes. before expanding any of these models. There's no mother may I built in. If CMS sees that a particular model is being successful and the CMS actuary affirms that in fact it's slowing cost growth or keeping it stable, then on its own CMS can expand indefinitely. And it's remarkable, frankly, to see that Congress is willing to cede control over Medicare and Medicaid to this degree. But it's very exciting to have that kind of broad mandate to test and expand many models. So one model that's received a lot of attention in the Medicare context is accountable care organizations. And to summarize, thousands of studies into 3 bullet points, the notion is you have physicians, could include a hospital, could include nurses, and you say, look, you guys are typically responsible for thousands and thousands of patients together. You guys get together, and most of your patients see mostly you guys. And so why don't you do a better job controlling the kind of care they get? Think carefully, think creatively, think as a team. And if in fact you can slow cost growth while maintaining quality and hitting various quality metrics, then we're going to let you share in the savings. So if your patients wind up getting hospitalized less and Medicare saves $100,000 on your patients, you all will get $50,000 or $75,000 to split up. That's the basic notion of accountable care organization. That's one model. Now, marbled throughout the bill, hence this little photograph, is the notion of a patient-centered medical home. And the idea, and we'll talk about what that means, but it's encompassed in so many different parts of the bill. Medicaid options to provide this coverage with 90% federal match. New Medicare experiments that are authorized. Grants from HHS, a new prevention center with $2 billion a year appropriated eventually at full implementation that can fund things that facilitate the patient-centered medical home. So what the heck is the patient-centered medical home? Well, the idea is it's primary care, but it's way more than that. It includes care coordination. And it's not just care coordination as in, a nurse from Phoenix calls your patient and says, have you taken your medicine, and you never hear about it. It's integrated into the medical practice as a part of the medical practice. And in a proactive management of care transitions so that when the patient goes home from the hospital, he or she has an idea about what to do. Patient education, critically important, helping people learn how to manage their own chronic conditions. 24/7 availability so that when the patient calls or emails, you can respond and get reimbursed for responding by email. And you can get reimbursed for telephone consultation. So the patient doesn't have to waste their time to come into the office if a more efficient method of communication would work. Now, obviously, patient-centered medical homes can be aided by health information technology, but they're not necessarily strictly essential. So given some of that as the background for PPACA, what are some of the opportunities for nephrology? Now, I have to give you a warning. What you're about to hear is an exploration into uncharted waters. And, we may or may not wind up going where I'm about to say that we're going to go. Here's some ideas. Take them with a grain of salt. Maybe they can spark some of the thinking on your own. Here's the idea, one idea. Patient-centered medical homes have usually been thought of in the context of primary care, but what if we had a patient-centered medical home for specialists? For a defined group of patients, in fact, specialists are managing the bulk of their care in the same way that a primary care doctor manages the bulk of the care for a relatively healthy person. So obviously in this case, somebody with chronic renal failure, it's the nephrologist who's going to be managing a huge part of the care. And as part of the so how would it be structured? Well, the point person would be the nephrologist who would be overseeing and coordinating the care, but you'd have a team. And you all may have heard that there's one notion of thinking about the change in medical practice that's underway is that what used to be an individual sport, an exercise of doctor heroes, is now moving into a team sport. And the patient-centered medical home model is very much a team model of care. So you have a primary care physician as part of the team. If somebody has a rash, they don't necessarily need to see a nephrologist for that. They can get referred. It's also nurses and social workers and patient educators. A physician isn't necessarily certainly is not the most cost-effective person in educating a patient, but may not even be the most effective. The patient may need education with somebody who has a level of cultural competence or linguistic competence that a particular physician, brilliant though he or she may be, may not really be equipped. And people may not want to do this. You may be, House, brilliant diagnostician. I don't think he wants to be working with, with patients intensively, and I don't think the patients necessarily want him to be talking to them every day about how to manage their condition. So nurses, social workers, patient educators, case managers, grand aids, Tim's superb idea, long track record of research to support this basic model about people in the community who receive education about a particular subject subject matter being empowered to work with other community members, having a level of credibility, a level of effective communication that other folks may not be able to manage. So that team can provide care in a way that's assisted by HIT, either via EHRs, ideally, electronic health records, or disease registry. That's the basic notion of a patient-centered medical home. Thinking about how this would work with patients who suffer from renal failure, it's worth thinking about the following attributes of a high-performing health system as identified by the Commonwealth Fund, which has been one of the leading supporters of developing the ways of thought that got into PPACA. Information continuity, so that whenever a patient sees a provider, that provider can tap into an electronic health record and see what services have formerly been provided and add to that record to reflect new diagnoses and new services. Care coordination and transitions, so that you don't have siloed care being furnished by lots of different folks. You have somebody who's proactively responsible for coordinating care and managing transitions. One of the lowest hanging fruit in terms of cost savings is rehospitalizations. People get discharged from the hospital, they're told blah, 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 blah in the hospital before they go, and they're in a haze, and they don't understand. And then, what was that person said? And they wind up in the hospital. Huge amounts of money get wasted, and we know how to stop that through at-home intervention. So managing transitions, system accountability for performance, peer review and teamwork, so that it's in fact all the members of the team are providing feedback, seeking external feedback, peer review to get high quality, high value care. Continuous innovation, not so I gather you all have talked about the kinds of health information records that Jonathan and his team put together, constantly looking, how can we do business better? What kind of healthcare services should we be providing? How can we organize ourselves better? Continuous innovation, and finally, easy patient access to appropriate care via the phone, via email, via in-person visits. So that's one model. Now, how would you pay for that? How would Medicare pay for that? We don't really know yet, and we're trying to work on it, we being the broad community of people and folks at CMS. But it's worth thinking about a few ideas. One is capitation to cover some services. Certainly, care management, patient education, things that need to take place on a routine basis make sense as a capitated payment. One can also think about other clinical services where instead of having minutely micromanaged particular services, we're going to pay you X for this and Y for that. So you know what? As a general matter, your patients are getting X plus Y plus Z, and we're paying you, V dollars. We're going to give you V dollars, and you can figure out X, Y, Z, maybe A double prime inside that basket to achieve the same goals, allowing some innovation. Now, one needs to be careful with this, obviously. There have been problems with capitation in the past. One needs to have risk adjustment, and that means you need good risk adjusters, and they're getting better. But are they yet all the way there? I don't know. You all probably know more than I do about that. Outlier payments, potentially. That's how we manage DRGs when those were implemented. Quality reporting and metrics to make sure that the incentive to underservice that's built into capitation doesn't actually cause patient harm. Fee-for-service reimbursement is the worst method except for all the others. Some services would need to be fee-for-service. Now, there's another interesting point we're thinking about, the shared savings model. Remember we talked about the accountable care organization? The idea is if a group of physicians in managing care can reduce cost or slow cost growth relative to a group of similar patients nationally, let them achieve the shared savings. Otherwise, why do you have an incentive to cut back on the cost of care? Maybe this could be applied as part of a specialist patient-centered medical home. If it turns out that Rogosin or another group of high-quality nephrologists putting together this kind of team, assuming this level of responsibility, if patient costs are less than one would expect based on national data about similar patients in similar high-cost geographic localities, then let that group, that patient-centered medical home, share in some of the resulting savings. If CMS is spending less on hospital care, then allowing physicians to capture that gives an incentive to to continue to innovate. Now, there need to be adequate adjustments. One needs a critical mass of enrolled patients so that random events don't distort reimbursement. So, but a lot of things you need to get in place. In fact, there are going to be a lot of steps required to make this model work in reality. What are some of the next steps that might be required? Well, developing a detailed plan, staffing, operations, including a rigorous evaluation plan that is detailed and careful, but also presents the opportunity for quick results, interim results. We can't afford as a country, it seems to me, and I know there are other observers who've said this as well, to wait 10 years to have the standard cycle of demonstration, massive evaluation, 5 years later out comes the report, then we scale it up again, and then before you know it, it's 2050 and we're all being killed by healthcare costs. So one needs to have a rigorous evaluation, but with the possibility of interim reports being presented. And then it's worth making a proposal, it seems to me, within the next 6 to 12 months, if you can develop it, to the CMS Center on Medicare and Medicaid Innovation to say, let's fund us, let's get going, let's try to test this thing out, see if it works. So in conclusion, patients with serious chronic illness are of great concern to national policymakers. And the reason why, well, was told by Willie Sutton, the famous bank robber years ago. Why do you rob banks? You know the answer. That's where the money is, exactly. And that's where the money is in healthcare. It's with the chronically ill. So policymakers want to know, can we slow cost growth with the chronically ill while maintaining or improving quality? And kidney disease patients present a beautiful example of a group that maybe we can do better with as a country without spending more money. And so now I've mentioned 1 or 2 ideas. Tim's mentioned other ideas. You all can probably come up with lots of ideas that are a heck of a lot better than mine, because I'm neither a doctor nor an economist, no matter what Tim has told you. But the main idea that I'm trying to encourage today is to think about innovative models for care delivery that hold the potential, based on what you know, for improving, or at a minimum, maintaining quality while slowing the growth in healthcare costs. And if we can test that out with this particular group of patients, maybe we can learn lessons that can apply to the country as a whole. So thank you very much.
Thank you very much for your kind invitation. And I work in Sweden, and I'm going to give you some experiences of our projects that we have driven during the last few years, and which looks into the future of nephrology, I hope. We all have the same challenge, and that is to decrease the rising burden of patients with chronic kidney diseases. And in most Western countries, we've seen a doubling of patients with end-stage kidney disease during the last 15 to 20 years. And we have approached this in several ways. I'm going to talk today a little bit about what we are doing about slowing the progress of chronic kidney disease, but we also have a great interest in maintaining the transplantation results in long term, and also reorganize our dialysis treatments. We have worked on introducing the estimated GFR on in a wide scale in general practice. And we also have worked on programs for care of patients with chronic kidney disease. And that means we have to increase our interactions with the primary care physicians and the nephrologists. And we have taken a lot of notice on how to select patients for nephrologists and for primary care physicians. And we also have adopted a new way of working in an integrated care between nurses and nephrologists. Estimated GFR means that we can detect chronic kidney disease earlier. And there have been threats. Many colleagues to me, they say, well, we are running out of nephrologists if we're going to introduce eGFR. But I think that's the wrong way of thinking about it. We must recognize these patients, and then we have to handle this problem. And I also think it's very important that the nephrological community takes the lead, and not the politicians, diagnostic corporations, or others, because we have the knowledge and we know how to set up a new organization. So both in Sweden, and I know that some parts in UK also have dealt with this when you introduce estimated GFR in general practice. You must assist in selection of the patients. which patients to be referred to a nephrologist and which patient to be treated by the primary care physician. And then we were discussing this in wide groups in southern Sweden, and after we had workshops and worked in after several meetings, and then we said we must set up some guidelines for the primary care physicians. And then we were working on algorithms using age, eGFR, and urinary albumin, creatinine, the albuminuria. And we ended up in a program like this. And this is a sheet that we have distributed to all primary care physicians in an area covering 2 million people. And these guidelines, they contain a definition of chronic kidney disease with the GFR levels here, and we give information about estimated GFR, albuminuria, and we also give some short recommendations how to use ACE inhibitors in patients with chronic kidney disease. What we think is maybe the most important is which patients suitable for referral. And then we were using age, urinary albumin, and the CKD stage. And this means that an old person with low degree of albuminuria, but maybe a CKD stage 3, could remain at the primary care physician and not be referred. But a younger person with albuminuria should be referred to the nephrologist. And we also give some information about what the nephrologist want to know in the referral. So based on a combination of age, eGFR, and degree of proteinuria, we try to select patients coming to the nephrologist or staying at a primary care physician. And here are some examples. An 80-year-old person with a slightly decreased or moderately decreased GFR, but with a low albuminuria, shouldn't be referred. A middle-aged person with fairly normal eGFR, but with a significant albuminuria, should be referred. And a middle-aged person with a moderately decreased GFR, but with no albuminuria, shouldn't be referred. And we also want to accept the referral. We recommend the primary care physician to give us some important information. That is, of course, new and old creatinine levels, medication, blood pressure, albuminuria, ultrasound of the kidney if it's available, the result, some laboratory tests, and the medical history. If they don't give us this, we send the referral back. And we have got some help from the government. And there is a strong driving force in Sweden to give financial incentives to let the patients stay with the primary care physicians and to decrease the outpatient visits at hospitals. And they've also transferred the budget for medication to the primary care physicians. So this has helped us in our effort to send some patients back to primary care physicians. But we knew from the beginning that this is a quite tough task because we need a good interaction between the primary care physician and the nephrologist. So we offer educational programs, we give these guidelines, and every nephrologist at our hospital, he is obliged to be a contact person for 10 to 20 primary care physicians on a regular basis. Apart from this approach, we also have started an integrated care at the hospitals between the nephrologist and the nurses. And we have specially educated nurses for these patients, and our aim is that every second visit the patient goes to the nurse, and every second visit the patient goes to the nephrologist. And this has turned out, we must say, quite well. And we also let the nurses adjust some of the medications. And the next project now is the follow-up of transplanted patients, because we have a strong belief that the nurses can do a lot of the job as well as the doctors, or maybe better, if we make an integrated care. So I will just say that 5 years ago when we started this, my colleague said to me that this will not be possible. And well, when I was young, I was taught that it was impossible to build a bridge between Sweden and Denmark, but now it's here. And now we also have this program for southern Sweden, and I think if you're stubborn and you want something, just do it. Thanks.
Barry, have you got some thoughts on what you've heard either really from Stan about, and this is sort of hard to ask somebody at the top of CMS to say something informal, so that's not fair. But moderately informal, not for repetition beyond that television camera. Have you got, I mean, just in terms of some thoughts of some of these ideas of ACOs or specialty patient-centered medical homes, do those sort of make sense in nephrology?
Yeah, and I think I can expound a bit on what I said this morning, which is, one, I think it's an incredible opportunity for the renal disease world. And we have had already discussions. You know, the way, if you read through the language and if you read through most of the folks who approach the agency, the thought has been for doing primary care focused accountable care organizations in most people's minds. But there are a number of us that have been talking for several years about doing specialty focused medical homes, accountable care organizations, or other models of delivery systems. And as I outlined this morning, I'd take it more than just, I think most people who come in, and so far it's been primarily large dialysis organizations who are very interested in this. But they're looking at it, I think, in a very narrow mindset. Specifically, they're looking at care in the dialysis unit, possibly the care that needs to go into supporting patients outside of the dialysis unit for primarily renal disease issues, primary renal disease, as opposed to the broader care that our patients in with end-stage renal disease require. So I'd still challenge all of us to consider the model, but think very, very broadly, and that is not just dialytic care, but chronic kidney disease care, and there's overlap between the two with the social workers, the dietitians, patient engagement, and self-management education. The list goes on and on. But beyond that, too, it gets into which is the best treatment modality for patients and assuring, not just talking to them, but assuring that they get which of the many renal replacement therapies we have available now, which is the best for those individual patients, and it includes transplantation. And then it includes, in the end, how these patients, regardless of the modality of treatment, are managed across the care continuum. So it's not just the dialysis unit, it's not just the physician office, and it's not just the hospital, it's skilled nursing facilities, use of home health agencies, use of telehealth, use of ambulatory surgery centers, vascular access centers, it goes on and on and on. So I think it's fertile. We ought to have more discussions. An invitation to kind of end my segue, and that is that we are always open to people coming in to talk to us about their ideas about what we should change about our current systems, but also in planning for implementation of the Affordable Care Act and the myriad other statutes that are affecting us that I talked about this morning. And so feel free to contact me or others at the agency. We can arrange to come in to see with the appropriate people and talk about this sooner rather than later. There will be RFPs put out, I think, in solicitation of interest in accountable care organizations, medical homes, and other demos. But this is an opportunity for the first time in many years for people to come in with ideas that may generate demonstrations, unlike before where they had to be very specifically statutorily mandated and or a pet project of a politician somewhere in the department.
Of course, those don't happen anymore. Isn't that great? Do either of the three of you want to react to things that, just questions, thoughts that the three of you had asking each other before we throw it open to the audience? I asked Anders last night whether it would have been his preference had primary care physicians not gotten the responsibility for paying for the medication prescribed by the specialist. You might want to tell us whether you think that that's something that the gentleman to your left should adopt or not.
Actually, our experience of that government, the change of government in that question is very short. So we don't know the long-term result of that change in the budget.
Is it accompanied by the murder rate of primary care docs by specialists as well, or vice versa? Okay, let's throw it open to the audience. I think there are microphones. Walk around microphones. Somebody's waving.
Susan's
I'm glad
way
you're
in the
waving,
back
but here comes Susan. Okay, there we go.
I'm Dr. Bart from Atlantic Dialysis. I have a question for Dr. Straub. If we go back and look at the ESRD program, of all the programs in Medicare, this is probably one of the most effective programs that we have. Go back to the composite rate in 1983, we used to get about $139. And if we were to take that $139 in 2010, our composite rate should have been about $310. That's based on the CPI. Yet, I think in 2007, 2008, that amount is only probably about 170. I don't think there's any other program under Medicare which has been that effective in controlling the cost. That's one statement that I have to make. And all the increase in dialysis spending has been on the basis of expansion of the program. I think in 1983, we had probably about 50,000 patients who were on dialysis. Now we have about 385,000. And the increase in cost in the ESRD program is mainly as a result of the growth of the program rather than we making that more expensive. I think it's not so. That's the statement. I would like you to respond to that. And I have two other questions. In the new bundle that we have, there are 14 case mix adjusters, which is going to be a nightmare for us. I have about 2,500 patients, 10 dialysis centers in New York City area. It would be a nightmare for me to collect all that CMA adjuster. I do not know how much of that money I'm going to get on the CMA adjuster. It happens to about 22% of the total bundle payment. And the third question that I have is that you guys have been telling that all these new rules are coming, they're coming. I think last week we had a poll where we are going to bet as to when exactly these proposed rules are coming. I'm told that it's going to be July 2nd, hopefully. From that, July 2nd, we have only 4 months to decide whether we are going to go fully bundled or we are going to go partially bundled. After you guys come up with the proposed rules, then we have to, people have to write the software, we have to prepare ourselves, and then the intermediaries have to do their job. I do not know how CMS is going to do that in about 4 months' time. Thank you.
And we'll certainly ask Dr. Straub to answer any one of those he'd like.
I may try to get to all of them with one answer that's hopefully somewhat short. First of all, on the composite rate comment that you made, when I've tried to delve into the composite rate history myself and make some sense of things, it's not quite as clear-cut, perhaps, as you were describing it. There are many people who argue that the original composite rate way over-reimbursed folks for the services that were being given. So some folks have argued that the fact that it didn't go up was a good thing, that it probably should have gone down. You may recall, I do, when I was just out of my fellowship, people were getting into the dialysis business left and right, and there was a reason. It wasn't necessarily to provide extra dialytic care to patients, because there were often 3 or 4 or 5 dialysis units within a few blocks of each other. It was a very profitable situation back then. So some of the lack of rise of reimbursement was probably warranted. The other feature, of course, was the separately billable drugs, which didn't exist, as we remember, those of us old enough, before Epogen and the vitamin D preparations and even the more expensive iron preparations were available. And those became money makers. So I think the whole composite rate picture is difficult to analyze looking back at it. I think the important thing right now is that we have to kind of reset the clock. We have to pick a reimbursement that hopefully will reimburse adequately for basic services that everybody should be privy to, and that there will be a bit of profit, if you will. I don't know how much is fair, but a fair amount of profit so that people can make a living on top of providing cost-effective care at that level. So that's our goal with the rule. In terms of when the rules are coming out, I said soon this morning, but I also listen carefully. I parse my words very carefully usually, and I said that I'm constantly checking my BlackBerry because for all I know, as I speak, we may have issued a rule. So I think that although this is subject to change, we're not allowed to announce a date because it goes through clearance, and just when you think it's about to come out, somebody will object and it gets bogged down with legal analysis and all sorts of things. But you will see something very soon, I believe. As to the implementation pieces, this is something we've chronically struggled with, that because of the clearance process primarily, it shortens the time from elicitation to when people have to be implementing it. So far, people always seem to be able to get there and do what they need to do. So we believe that it'll be issued, and people will be able to get things implemented in the time frame that they need to. Remember, some of this is going to, you're right that you have to make a choice early on, but regardless of choice, there is some phasing in of a number of these provisions too, and it gives us time to react if something's not going right, to change things in midstream. I think the only, you did mention about case rate adjusters too. That, as I put this morning, was one of the very significant feedback that we had. And I'll have to leave it to when you see the final rule. I hope you'll think that we listened to any number of issues that were proposed to us.
On the broader subject, is this on?
It is.
On the broader subject of the administration's implementation of health reform, I can tell you I'm not alone in having been astonished at how quickly they've been moving on implementing health reform. I mean, just a few things that come to mind that have been done already is provisions regarding early retiree coverage and subsidies for reinsurance that are now available, guidelines on the obligation to provide coverage to adult children up to age 26, which had to come not just from HHS but also from IRS because there are implications about what kinds of employer contributions are tax exempt. A request for proposals from states for grants to implement insurance company rate review, clarification about the rules that apply to the already in effect prohibition against pre-existing condition exclusions for children, and new rules for the scaled back Medicaid benefits package that can be applied to the newly insured. Those are just a few things that came to mind since your question. If I had more time to look at it, I could probably give you 4 or 5 more. It is unbelievable, given the huge number of responsibilities placed on HHS and the relative absence of administrative dollars, how quickly and thoughtfully they've been implementing this thing so far. I hope it continues without burning out too many people.
Yeah, we've actually been working on implementation since the end of last summer. Remember, the bill wasn't passed until March, or signed by the President until March. But we were going on the Senate bill, and so there was a lot of planning put into this. And to add to Stan's nice list, as we speak, the $250 checks to those beneficiaries who are in the donut hole are going out. Although I'll warn folks, that's going to be confusing to a lot of beneficiaries. Lots of beneficiaries will assume that all beneficiaries should get $250, and it's only those who are in the donut hole or who get into the donut hole later in the year. So if you have patients complaining to you that they haven't gotten their $250 check, there is probably a reason for that.
Probably time for one. Ready. We got, or Scream, or Susan, you got the, okay, here we go.
Hi, one question. One is the access issue. We talk about not being able to get a Medicaid doctor in Boulder, Colorado. If you go to the hospital, our community hospital's urgent care center, and you have Medicare, they will not treat you. You have to go to the ER. But the question I really had was, we talk about the insured and the uninsured, but an awful lot of people I know have $5,000 to $10,000 deductibles. And if they get hit with an ER visit, they're in trouble, in deep trouble. What happens with the deductible issue?
Well, that's a good question. The legislation has new limits on the maximum deductibles that can apply in the group market, in the small group market. It's $2,000 for individuals and $4,000 for families, and that gradually increases over time. Also, in terms of the subsidies in the exchange, I'm a little worried about it, to tell you the truth. I mean, there are safeguards. There's a requirement that preventive services have to be covered without any cost sharing, and it's defined broadly based on any, among other things, any service receiving an A or B ranking from the National Task Force that looks at preventive care services. But there are actuarial value standards in the exchange. So this new health insurance marketplace That's going to be open to employees of small business. If the small businesses say they want to participate, or individuals who don't have access to employer-sponsored insurance, there are going to be 4 different tiers of health insurance that cover 90% of all services, 80% of all services, 70%, etc. Some of those plans will have high deductibles, and I have to tell you the truth, I'm worried about it. I mean, one of my big worries about the legislation is that some of the, I'm not worried so much about Medicaid, but I'm worried about the folks above the Medicaid line, the premiums they're going to have to pay, the level of out-of-pocket costs they're going to have to incur. You know, they had to come up with something that, according to CBO, paid for itself. And the more generous the subsidies are that you provide, the more you have to come up with tax revenue in the other end. So, you know, they did the best they could, but I'm worried that the subsidies may not be good enough.
I think just to piggyback on what Stan just brought up, remember back, there's a history of this with other pieces of legislation too. So if you look at the Medicare Part D drug benefit, there were a lot of people very unhappy and still are unhappy, many, but unhappy with the donut hole situation. But it did get implemented. It has added, it's not perfect yet. This bill is trying to affect that. I think even when it looks imperfect, at least we're making hopefully some progress, and we'll move forward and we'll correct things that don't look good.
Right, and there's out-of-pocket maximums too in the bill, and there's also a prohibition against lifetime limits. Like insurance companies in the past have said, you know, we're only going to pay X dollars, and you know, if you're X plus 2 million, well, you have to take care of the 2 million, honey. You know, that's going to be a thing of the past. Unreasonable annual limits are barred by the bill. So the bill, I think, makes significant progress in addressing the issue of underinsurance, which is what your question gets at. It doesn't solve it, but it makes significant progress, and I'll take that.
We had one more, Susan. As that's getting there, I guess, Barry, it would be good for me to tell the truth about where I think you and Stan come together, and that is the responsiveness of all of you has to do with who you are. And you and Marilyn and Ariana and the whole crew at CMS have been phenomenally responsive, and the whole department for that matter. So, I mean, I think I can't say on behalf of the medical profession, but I'm going to say on behalf of the medical profession, we thank you. Because there have been generations of people at CMS that were not responsive. So we thank you. Yes, sir.
Dr. Vlase, Suffolk Nephrology. I have a question to Dr. Straube and the panel. And you were discussing about ASOs, or medical home, and the possible role for the nephrologist. I just want to briefly say that about 8 million of patients with CKD are in stage 3. And what is your opinion in including CKD clinics in such an ASO model, where you would shift attention to prevention and avoiding progression to later stages of CKD, based on the fact that there were certain studies already done in the United States, and a significantly large paper was published in 2008 by Dr. Nissensen on CKD in the United States, a public policy imperative. That was the question raised, and about 19 barriers to effective nephrological health care were raised there. And also by the fact that a CMS-sponsored activity, the Key to Better Health project, has shown certain benefits. So do you think that it would be essential to run a pilot study at the US level to prove that that model stands?
Again, if you may remember that this morning, and I mentioned it a little bit earlier on this panel, that I think CKD very definitely needs to be part of the renal disease approach. The financial statistics I mentioned this morning, you know, we spend 24, 25 billion a year on end-stage renal disease, but we spend about 65 billion on all renal disease in the Medicare population alone. So there's a huge additional expense to chronic, far advanced chronic kidney disease in the Medicare population. That's not even including Medicaid. So I think that's an essential part of the mechanism. I think we're again, as I said this morning, it's one of the benefits of having a nephrologist be able to get into the role that I was able to get into. I've added to our quality improvement organization program a task on chronic kidney disease specifically, which was done in 14 states at the present. Actually, no, we did it in all 50 states. And we're going to be continuing that in the next statement of work with the QIO program. And we've been aligning the QIO program with the end-stage renal disease network programs. And that includes dealing with things like fistula placement. Obviously needs to be placed ideally prior to needing a catheter and getting started on dialysis. So there's a number of efforts to try to align chronic kidney disease, end-stage renal disease. I think the other area that we're advancing on is, and this gets back to Tim's Grandaid's suggestion, and Stan mentioned that, we have actually we have 6 states that we're working with diabetes self-management training, and we're expanding to start some kidney disease self-management training in states as we expand that. The one state that we've done it most significantly is the state of Mississippi for diabetes self-management. We picked that state and started our project in November of last year. It does not use the traditional model of using physician offices and hospital settings for diabetes self-management training. We were able to expand payments to pay community health workers and other individuals who were unable to be paid to provide those services. We use promotores, we use any number of other non-traditionally clinical people similar to the Grandaids program. And that is leveraged with our working with the Agency on Aging, with the Health Research Services Administration, HRSA, with the Department of Housing, Urban Development. We go out to senior housing centers to do these kinds of things. It just goes on and on and on in terms of partnering with other agencies, working at the community level, using non-traditional community resources, and using non-clinical individuals to help with training. And so that model, which we're going to expand, we think, into Texas, focusing on the Latino community, that will apply, I think, to diabetes self-management, kidney disease self-management as we go forward too.
You'll see our grant in about 45 minutes. Thank you, panel. You're terrific. Dr. Smith, back to you.
We're right on time. I think, I hope you all agree with me. I've found this to be a remarkable journey today through new health reform policies, the electronic medical record or health record, dialysis technologies, acute kidney injury and repair, transplantation, immunology, tolerance, xenotransplantation, molecular genetics, and some very specific suggestions for new things that we might try as nephrologists. So I think going back to Charles Dickens and A Tale of Two Cities, I think we can really say it is the best of times. And what that means is that we have an opportunity as nephrologists and those interested in chronic disease generally in the area of 4 states, really, Pennsylvania, New Jersey, New York, Connecticut, and beyond, to take advantage of this opportunity and to work with CMS, propose some new ideas. And I think all of us are responsible for taking that initiative. If we don't, the opportunity will be lost and we will not be able to, I think, do all that we could have done for our patients. And that would not be a good thing. So I think we should thank all of the speakers. They've done a terrific job, and the dialogue that we've started today, I would say we're sort of mapping out a territory and sensing where the opportunities, particular specific opportunities lie. We see this as launching a continuing dialogue and effort and action-oriented program to make a difference, as I said, in patients' lives. So I'd like to give all of our presenters a hand. that includes those that spoke earlier, not just today. And thanks also to all of you for taking a day to do this, be with us. We do want to work together. We will be back in touch with you by the internet, websites, telephone calls, whatever is appropriate. We hope that we'll have another symposium next year, but in the meantime, we have a lot of work to do, and what we'd like to do is have next year a time to report on the things that have been implemented, the actions that we've taken. We should also thank Rockefeller University for letting us have this beautiful facility, and to the staff that's worked with us, and I think also to the staff of the New York Presbyterian Healthcare System office, and to our staff, Susan Spiegel and Jennifer D'Antoni. I think they've done a terrific job in making the day smooth, and things have worked well, and we're finishing on time. So just thank you all again for being here, and this is just the beginning. I had a professor at MIT who said, "You ain't seen nothing yet," and I think that's probably a good note to end the day on. Thank you all.